Welcome to the CE module titled Conducting a Health Claims Data Analysis, Planning, Targeting, and Evaluation. Our agenda for this module includes a perspective on claims and on the health claims production process, helpful data sources, key limitations of health data and claims data, basic patterns of expected utilization and cost, analytic insights, data utility, applications to the wellness field, and a summary of key points. Now, as we think about the origins of health data and the actually conducting of health claims analysis, we need to recognize the complexity of the process that we're looking at and attempting to gain some insight into it. The U.S. healthcare system is the largest healthcare system in the world. It provides care to about 317 plus million people each year. About 30% of those do not use any healthcare services, but do in fact have the rest of the 70%, the other 70% utilizing all those services. There are about 1,900 plus health plans, and that includes the Blues as well as commercials, commercial insurers, as well as PPOs and HMOs. So we have a lot of players in terms of providing healthcare system and healthcare activities. We have more than 48,000 ICD codes, and that's International Classification of Disease. It's got a longer name, but ICD for short. But the idea that those 48,000 codes that relate to diagnosis are then connected with and need to have some appropriateness of rationality in some 24,000 different current procedural terminology codes. And that's handled through the American Medical Association, and they update those codes as healthcare and the processes of healthcare change. And then we have approximately about 14,000, a little less than 14,000 separate drugs in what's called the U.S. Pharmacopoeia, which is our kind of the collective combination of all active drugs. If you included the various dosage levels and the amount of those drugs, you would have probably more than 50,000 different drug combinations that are possible. So we're talking about a very complicated, a very significant amount of activity. It represents a little over 18% of our gross domestic product. In the 2015, it accounted for approximately $3.2 trillion of spending. That puts the healthcare system of the U.S. In line as the fourth largest economy in the world, after our own economy, the Chinese economy, and the German economy. So it's a very big undertaking, and it's a very complicated undertaking. And we need to appreciate that as we think about the origins of the data that we're attempting to get at to look at its implications for wellness programming. Now let's look at the issue of what is healthcare data and where does it come from. And if you think about the process of healthcare, I as an individual make a choice to visit my doctor. And that encounter with that healthcare professional, a physician, does in fact have implications to it that occur in that office. So during that visit, the physician is attempting to find out what is the diagnostic code that accounts for the reasons, or either one reason or multiple reasons for the visit. There also may be then the association of what should be done for the individual, including a full range of options and alternatives that include prescription drugs, as well as further diagnostic tests, as well as potentials for surgical intervention and other forms of medical intervention. So we have this process taking place where the doctor staff codes all the aspects of the visit. And the expansion from ICD-9 to ICD-10, which we have done recently, is in fact an expansion to get us up to the level that the World Health Organization recommends in terms of the amount of detail in the diagnostic activity and the treatment activity of healthcare. So we then send off a claim, and the claim is processed. It's manipulated, classified, edited, categorized, picked apart, reassembled, adjudicated, remitted, and then stored. So that's all the work that the health insurer is usually doing with that claim that has been passed on to them. Hopefully it's stored in a safe place, and that's where we want to be careful according to the HIPAA provisions, the Health Insurance Portability and Accountability Act requirements under Title I that attempt to have us all prevent unauthorized disclosure of individually identified health information or protected health information. And then finally, we come to the stage that we're going to move into in more depth, is looking at the analysis of the data that this particular process generates. Now, let's look at some helpful data sources and their utility. And as we look at the type of data, you can look down the various kinds of things that we collect information about, and most of those have to do with needs assessment. You saw them in the Level 1 program under the skill number 2 that had to do with assessing the wellness needs of your population. And they include historical data, demographic data, key informant data, interest survey data for new programs, focus group use, design team use. And you can see the rough parallel of the amount of utility. The more pluses that are listed under planning and evaluation utility, the more that those particular types of data can be used for either planning purposes or evaluation purposes. Most of the time, our claims analysis is going to accomplish both of those two things. It's going to give us information to help us plan the wellness program, and it's going to give information to help us evaluate those programs. Now, when we look at the two areas that we're really focused on in this particular module, we're looking more deeply at medical claims data, and you can see that there's more utility on the evaluation side than the planning side. In addition, in the prescription claims area, the prescription drug area, the same kind of relationship occurs. So we have more utility coming from evaluation versus planning. One of the types of utility that are not in this, we'll see this later, is targeting utility, which just means does the health claims information allow us to target particular people in the population we're attempting to serve for any kind of specialized interventions. So we'll talk more about that later on. As you can also see, there are claims data that comes out of workers' comp, out of sick leave, out of disability, it's short-term and long-term disability, out of presenteeism-related data, and out of Family Medical Leave Act data. So again, you see our attempt to try to give you some idea of what our perception is about the potential utilities in the planning area and the evaluation area of various types of data. Now let's go deeper into the the two teal areas in terms of setting up the process of a health claims analysis. Now, before we set up that analysis, we want to look at the limitations of health plan data. And first of all, health plan data is generally hard to get. It's not necessarily released with any without a good deal of pressure being brought to bear on health plans. Health plan data is usually expensive to use. It is oftentimes complex. These systems of adjudication of claims don't necessarily produce clean health claims data. Health plan claims data can also have errors, and if the errors have not been backed out or edited out of the data, it can give us false indications. Health plan data is also rarely definitive, meaning it doesn't tell us everything we usually want to know. It tells us something that helps us increase our awareness or our insights about the process, but don't necessarily tell us all of the why questions or the why answers. Health plan data is difficult to extrapolate, so we have to be careful when we do extrapolate it because it is oftentimes presented in a way or derived in a way that makes it hard for us to extrapolate it to a larger population. And remember now, around 30% of the population don't use any health care during a given year, yet health claims data systems only count the people that have submitted claims. So it does make it hard for us to extrapolate. Health plan data has multiple confounding variables. We're going to look at more of those in a moment, but the major ones are age, gender differences, plan differences, claims processing differences, morbidity or experience from illness and injury, and educational effects. So there's a lot of confounders when it comes to how we analyze health claims information that it comes from healthcare utilization of various people in a population. However, health plan claims data is considered the smoking gun for determining the value, particularly the return on investment value of wellness. So these are some of the limitations that we are confronted with when we want to use health plan claims data. Now, other possible reasons for health cost changes, because one of the things we're attempting to do oftentimes is we want to see what happens when we do a wellness program. Do people actually use and need less health care? And are their costs lower after doing the wellness program? So there are other alternative explanations and reasons for health cost changes. It can include a non-random loss of subjects from participant or control groups. So if we've structured our claims analysis to look at participants or look at non-participants as controls, there sometimes is a non-random loss of those subjects, which means there's a bias creeping in. Changes in the health plan design or administration. We may have changed vendors. We may have changed into a new claims data system in the same vendor. We can have changes in health plan or provider vendors within the health plan so that they're using different vendors because they've contracted and negotiated different arrangements. There can be changes in plan enrollment policies. So we may have, as an employer, have changed our policies around who has access to the health plan. We may, in fact, have significant change in the size or the location of the workforce. And we may have significant change in the demographics of the workforce. Perhaps we have, in fact, maybe merged or acquired or decided to build out a new department, and that creates a distortion in the population that we're attempting to follow. We also can have loss of actuarial credibility of the participant or control group. So the numbers can get down low enough, and we generally think of them as under 1,000 as being in the more difficult actuarial credibility. Over 1,000, we tend to have actuarial credibility, which means we can assume certain things about the data that's coming from that size population. We also can have errors in reported health claims costs. So we may have double billings that don't get backed out of the data system, so it reports out more utilization than is really there because it's an error in a processing or an error in submission. Unusually large number of major claims, so those large claimant cases can distort things because data in healthcare and healthcare utilization data is not normally distributed. It's highly and heavily skewed. So it means a small amount of numbers of people actually use a lot of our health claims dollars. We also can be dealing with the various changes in utilization that may occur when people feel their jobs are in a threatening situation. They may get laid off, or there may be adverse labor or employment actions which cause people to utilize services different. They may choose to do things they've been putting off for a long time. So that may distort how much healthcare cost and healthcare utilization occurs. There also may be unusual morbidity patterns or events. We've had various kinds of things like Asian flu and pandemics of different types that actually create more healthcare use, but it's related to the pattern of the unusual occurrence rather than the effects of a wellness program. We also can have underreporting of claims as an artifact of plan design or incentives. So maybe people submit the claim to their spouse's insurance and it doesn't show up on theirs because the employer, if the organization you're perhaps working with has something in the plan design that creates an incentive for people to file claims in under another health plan that may provide coverage for the health care being delivered. So there's that underreporting problem. There's also misapplication of economic return methodology. So we can actually make mistakes in the assumptions we make about the population, the econometric assumptions that we generally derive, or we may have codified people as participants when they weren't participants, or as non-participants when they really did participate in the program. So there's a lot of changes that can occur there. So these are some of the possible reasons for health cost changes that may not be related directly to the attribution of causality between a wellness program and an observed effect on the health claims cost of a given population. Now, we mentioned briefly a moment ago that healthcare spending is not normally distributed. And this particular graphic kind of shows this in a more substantial visual form. It just says 5% of your employees, by looking at the left on the bottom, percent of its employees, 5%, would consume on average about 53% of all your healthcare claims. And that would add up to about a $20,000 per person. And these are oftentimes the complex, multiple problems requiring aggressive, unique case management and or other types of problems. So these can be the major kinds of claimant costs. If you look at the other groups, the 10%, the next 35%, and the next 50%, they in fact use and utilize a progressively smaller portion of the claims cost. So 10%, the next 10% after that 5% of heavy users or high users would perhaps use about 25% of all the claims dollars. The next 35% would use about 19 or 20%, and the last 50% are going to use that 3%. And part of that 50%, essentially 30% of that, 30% of the total 50, would not use any health care. So that again gives us this very highly skewed kind of phenomena when it comes to healthcare and healthcare utilization and cost. A small percentage of employees account for a large percentage of claimants and claims costs. And that's why we have to have actuarially credible sized populations to do any kind of claims analysis. And that tends to be around the area of 1,000 life years, 1,000 people. Now that could be 2 years of 500 people to get to that 1,000 life years. But the idea that the 1,000 life years is a general threshold in the field of actuarial science. And the actuaries are essentially mathematicians that apply their skills and expertise to the insurance industry. And health actuaries work in the health insurance field, whereas life actuaries work in the life insurance field. So that's the kind of activity that is done, and usually the more rigorous ability to look objectively at the experience underneath an insurance program. Now, this particular data comes from the Health Management Research Center at the University of Michigan. It essentially shows you the age of the individual that goes across the bottom. So if we have people from the age of 1 or less than 1 to 100 years in age, if you look all the way along that, what you end up seeing here is data that's been combined from a large number of samples. And the sample size is the light blue with dark blue boxes, that line. And that corresponds to the numbers in the axis on the right-hand side, which is the numbers of people that were in this sample that is attempting to really look at what's the average or mean medical payment and the average or mean drug payment for people at different ages in a cohort in the population. So what you see on the left-hand side is the per capita expenditures on healthcare per year. So those are the annual per capitas. So you can essentially see that at very young ages, there's kind of an uptick. And then you see, if you follow the blue bars, you'll see changes in the amount of healthcare use, but then they steadily build up to the point of the age of 65. So that is when Medicare takes over. And because Medicare has a lot of payment controls, it lowers the per individual by age cost. And it begins to kind of bring it into a plateau kind of relationship. Now, remember now the line with the light blue and the dark blue boxes, that's the sample size. So it would be ideal if we had a very large sample size across all of this population. But again, this is data that has been pulled together from a variety of employers to give us an idea of what is the level of expenditure that we can expect at different ages in the population. And there has also been work that's been done that tends to show that for each average age increase, from 51 to 52, that there will be around a 4% increase in healthcare cost for that individual. So that's the effect of the claims cost, the price, and the type of service used. And that again gives us an idea of how much is likely to be spent by age on an individual in a circumstance of having fairly large sample populations to look at those costs. So this gives us some medical and drug cost information and expectation by the age group in the population. Now, as we set up a health plan claims analysis, we generally want to have clean claims data, which means it needs to be edited and errors have been removed so that we're looking at clean data. We generally want to have more than 500 lives. Now, 1,000 lives would be a better threshold in terms of actuarial credibility, but there are circumstances around the way that we handle the data from those samples of 500 lives that we can consider it as actuarially acceptable. So that's what actuaries do when they're looking at claims data and attempting to get an idea of what kind of pattern changes are taking place. We must have the date of service because the date of service allows us to put it into a time category of either a baseline or first year, second year, third year from the program's activity. So we have to have that date of service. We generally want to use full years because there is some seasonal variation in healthcare utilization. So those seasonal variation we want to take out of the picture by using full year data from the healthcare utilization and cost. We generally must be aware of actual intervention timing. So it's not that your program starts day one and it all rolls out day one. It actually comes online over time. So if you are going to phase in an intervention, you can't expect a large amount of effect if only a half of your population actually gets some intervention during that first year. So we need to be aware of when the program actually was delivered to the people that we're looking, whose claims data we're looking at. And then we must be able to segment participants and non-participants. So that means we just need to be able to identify them in a way that the individual or the group that's doing the claims analysis can separate their claims out and look at them, look at the baseline phenomena, and then look at the first year of the full program, and then second year, third year, and so on. Now, the plan design features influence the request. So the plan type will influence that. It's not likely you'll be doing any kind of analysis of HMO data because HMOs generally don't report or provide data that allows you to track individual utilization. If it's benefit coverage and you don't provide coverage for certain things, then it's going to not be able to be comparable with other data that has that benefit coverage. There may be benefit limitations that have changed. So there may be only a certain amount of money allowed for chiropractic visits, or maybe a naturopathic benefit was put in place. So there may be benefit limitations that change over time. There also may be point of use cost sharing that's changing. So maybe the deductibles went up, and if that kind of change went on, you then have to factor that into your analysis because it's changing the pattern of what you're going to be seeing in terms of claims and the cost of those claims for a given period of time. There may be changes in maximum out-of-pocket limits. So that may change what is being paid for by the individual versus the health plan. There also may be utilization management requirements. So we may have required either a prior authorization or prospective review or some other kind of issue that's going to change the way people are using healthcare. There also may be consumer and or patient role differences. So we may have done some things to enhance the consumer's role, and that's also having an effect on the claims that they're experiencing. So that's another area where the plan design is going to influence the requests that you make. Also definitions, and from various providers use different definitions of what services are covered and what services are computed or looked at when they're doing any kind of utilization or claims analysis. The types of health claims data can be varied. So you can see here health plan data, oftentimes called medical plan, vision care, dental, prescription drug, workers' comp, sick leave policies, short-term disability claims, long-term disability. So the types of health claims data will vary depending on what we're attempting to look at and the period of time we're doing that for. Axioms about health plan data. So here are some things that I've found over the years in doing a number of these. First of all, there is a concentration, a required concentration of health claims data and health plan data. If we don't have sufficient numbers, we don't have adequate concentration. There's also a high degree of skew. So we have usually those few people using a lot of services, they distort our ability to look at the averages and means of cost in a population. So we have to be careful about the skew. There are also large claim cases. So those large claimant cases can in fact change significantly the economics that you see in a claims analysis. There's also the phenomena of revenue generation, and that just means that our healthcare system makes money from providing services and treatment. So there is a general bias toward more care and more treatment. And that revenue generation may in fact influence the amount of healthcare that a given population and individuals in a given population experience. There's also some small group dynamics where we get into the effects that a small group of people have on each other as they utilize healthcare. Maybe it's people who become aware that there's a certain kind of medical service that's available and it's better in a particular kind of diagnostic situation, and then that kind of creates some additional use. So we have some small group dynamics going on. We have non-users, which oftentimes are not included in our claims data systems because if you don't file a claim, the system doesn't see you. So that's something that we have to be careful about because we want a good portion of people to be healthy enough that they are not using health services of any kind. So that's a non-user related issue. The claim systems themselves can be quite different. So each health plan has developed proprietary means of evaluating the claims, the procedures that are carried out, the claims that are conducted, and how that is examined and adjudicated in a claims data system. There's also the availability of data, and health insurers generally don't want to share data about the utilization of people because it tends to cause the employer to want to get money back when they oftentimes don't see the extra money that the health plan has to come up with last year. They only see this year where their claims are down and they want money back. So that's why health insurance companies generally don't want to share health plan claims data. But that also is what makes it difficult for us in the wellness field to use any kind of health claims data gold standard to try and show the return on investment from medical claims effects of our wellness programs. And we have employee versus dependents. We have issues that have to do with, are they coded correctly? Are we ending up seeing the right people in terms of that claims data? And there are a variety of different errors that occur in a complex claims management system and claims data system. Now, we also have healthcare utilization data, and these are some of the types of data that we can ask for. And as you look through here, the physician visits, emergency room visits, diagnostic tests, prescription drugs, hospital days, hospital stays and days, home health services, physical therapy services, complementary and alternative medical services. That's where the chiropractic, naturopathic, reflexology, all of the variety of complementary and alternative medical practices, and specialty services and modifiable claims. Now, modifiable claims are important for us, and we have a tool in the back of the Level 1 book that helps you, and Level 2 book, that helps you actually sort out what are those potentially modifiable claim ICD codes. So that's another kind of analysis we generally want to look at when we're thinking about claims analysis. Now, the claims analysis process itself usually involves these steps. Step one is assessing the patient chart. So if someone is doing that process, usually it's within the physician's office or the healthcare practitioner's office. Step two is the pre-coding activity. It's determining what code range and what code potentials are there. Step three is the actual coding application, where we're looking at the ICD-10 and the CPT for the encounter. Step four is a quality check, and step five is client feedback. That's oftentimes the process that the health insurance firm is going through when they are doing this kind of analysis. We tend to have much easier access to health claims data when we are self-insured. When we're part of an insured pool, it's much more difficult for us to get health claims data from an employer. And the comparisons to norms for more than expected for the amount, less than expected, faster growth than we anticipate, slower growth, a more significant pattern, and we can also expect that claims data will not tell us the why of the what. It generally is telling us the what, and that's that comparison to norms for the various kind of patterns of those claims. But it will not tell us why that's going on. That's usually left to a further analysis. Now, useful claims related data can include per capita medical cost, which is 3 to 5 year, looking at what's happening with the trend lines. And those trend lines are translated into what we call medical trend. So we are looking at those per capita medical costs as medical trend, and we usually want to look at a 3 to 5 year pattern. And we want to look prior to the program, what was the trend, and then after the wellness program has been put in place and started to reach people, what does the trend line look like? The major diagnostic category distributions help us look at the categories of claims like circulatory disease or cancer, neoplasms, or low back pain or low back dorsopathies, or issues around accidents and injuries or routine maternity care. So those MDCs allow us to look at the general coding around the claims. In addition, we can look at physician visit rates. So we can expect to see some things occur and changes to occur in that area. We can also look at hospital days per thousand, and that's oftentimes how we look at the intensity of hospitalization and its use in populations. And we also can look at workers' compensation costs, which can include the incidence rates, how many new cases, but also the severity rate, which is the average cost of each case. So there's ways of looking at the workers' comp. We can look at claims by site and cause. So we can do a little deeper look at what's the pattern of claims is. We can look at sick leave days and hours. So that's another way that we can actually encounter and look at the effects of a wellness program on a population. And we can also look at disability days, short-term disability and long-term disability days, and the costs of those for the populations that we are serving or reaching. So in summary, these are some useful claims-related data metrics that can help us do that analysis and watch things, in particularly in what are called time series kinds of analytic designs. where we're looking at, the 3-year pattern or 5-year pattern of what our various metrics are showing us about the effects of the wellness program on a defined population. Now, the utility of claims analysis, if we try to capture its 3 major utilities: the planning utility, the targeting of individuals that I can reach out to proactively, and the evaluation of the overall wellness program. We've tried to give you some idea about the types of data, so we can look at the issue around the primary care medicine, the MDCs, the major diagnostic categories, the MD visit rates, the selected ICDs. That's where we pull out selected kinds of issues which relate back to the risk factors that we're dealing with in a wellness program. Emergency room use, workers' comp, disability, and it just gives you an idea of what kind of level of usefulness we can get, the utility of that kind of data in applied to planning, targeting, and evaluation purposes. Now, the uses of claims analysis and wellness are usually these. First of all, our planning. So that's a baseline on modifiable claims costs. So one of the handouts with this particular area is a handout which shows you a code, a list of codes of ICD codes that you can look at for modifiable claims costs. You can also look at the pattern of claimant cost, and that's the issue of kind of the size of the claimant cost, the percentage of people that don't use any health care. You want to kind of see that go up as you do things like medical self-care training or consumer health education or injury prevention or ergonomics or advanced directives. You want to be able to see some of changes in those areas. Our risk factor selection, so that's when we are working on what should we be looking at. We may then take a series of types of data from our health claims process and actually derive likely health risk factors that we should be focused on in our wellness program. We can also then focus our medical self-care, consumer health education, and injury prevention planning activities around what we're seeing in terms of the claims data that is being analyzed for the population that we're working with. In the targeting area, we may be looking at selected prevention targets. So we may be looking at the rates of utilization of preventive screening. And then we may be adding that to screening which is provided on site and allows employees to utilize that screening at the work site. We also can have individuals by the need that they have. So that claimant analysis and the claims system analysis can have fairly complex and sophisticated filters or protocols which help us identify, for instance, individuals who may have had 5 or more emergency room visits in the last 6 months. So that's somebody who can probably need some help from a wellness coach or a health coach or a nurse that's going to help them. So there's a variety of different filters, and we cover those in the more advanced levels of training for the WellCert program. But those various kinds of thresholds and filters are oftentimes what we use when we are targeting individuals for intervention based on their claims data. And then the evaluation can include modifiable claims costs, which we talked about earlier, and then the revisit or revise the targeting on our various health risk issues or behavioral issues that we're looking at in our wellness program, and also perform a medical trend analysis. So we can look at what is the growth in those per capita costs for participants and non-participants. How do we in fact see the wellness program affecting people who are using it? And how does that come out in terms of actual changes and differences in cost that they're encountering in terms of utilization of healthcare? So these are the primary uses of claims analysis and wellness. Most of them end up producing various kinds of metrics, and the metrics are then used in an analytic way to help us understand what's happening with the population and also to document or determine what effect the program has had, the wellness program has had on some of those key metrics. Now, the summary of key points are as follows. First of all, we want to ask for the data without individual identifiers or in aggregate form, because there's nothing that prevents us from doing that. If your insurer is telling you we can't give you individual data on individuals, you just say, don't tell me the individual's identity, but give me the data in aggregate form. I want to have the data for all the participants or all the non-participants. There's nothing that precludes that from being done by an insurer based on a HIPAA issue or any issue that comes out of privacy and confidentiality. Because anytime you aggregate the data and you can't walk back to a specific individual from the data, it removes it from consideration under HIPAA. Ask for the data for program participants and non-participants grouped separately so you can look at them individually. The strongest position for asking is when you are self-insured, and the weakest is when you are fully insured and in a large pool. You're generally not going to get information in that circumstance. Marketing and account reps will usually promise more than the information technology people will be able or willing to deliver. So oftentimes during the sales process, everybody says, oh, sure, we'll be able to get you all that healthcare data and you can use that claims analysis. And then when you go to get it, you oftentimes find people saying, well, I'm sorry, we can't give you that information because HIPAA requires us not to release it. So then you get into the kind of the long dragging out attempt to get the data. It will always take longer than you think. So whenever you're dealing with data in any kind of health plan or health care situation, just plan on a fairly long, protracted kind of time. It is never illegal or inappropriate for you to ask for and get aggregate claims data. So there's nothing that prevents you from seeing data in an aggregate way, and particularly when your company's paying the bills. Insurance companies generally do not want to give claims data to anybody because it exposes their margins, and they are worried about getting fired or getting their health plan removed from coverage for the employees by the employer who's seeking a lower cost option. The smaller the number of employees in their health plan, the harder it is to get claims data from them. And sometimes you must threaten to take your business elsewhere to actually get claims data. And I've had a number of those kinds of situations where the threat had to be so intense that it got kicked up to the higher levels in order to be able to get data. And it is usually difficult to get accurate utilization data from insurers. It's gotten better over the last few years, but it's still a problem to take claims data and convert it into clean utilization data. For detailed claims data using non-standard measures or data, it may be very expensive. So anytime that you are having and asking for things in a way that the health plan does not keep data in that way, that's going to become expensive. You will need to constantly check on the definition of key numerators and denominators to make sure they have not changed over time. So you want to be careful in looking at things that are numerators and denominators. Always clarify the definitions of key terms in all data reports. Look for full function use of claims data, so attempt to get full utilization out of its utility. Now let's cover some key questions. Our first question is, how valuable is claims data? And I would say it's very valuable if your population is over 1,000 lives, particularly in both your participant population and non-participant population. That's got to be a very valuable asset for you. Its value is much less if your population is smaller than 1,000 lives on either the participant or non-participant side. I think that selected metrics and time series analysis can be very valuable when you're looking at issues like preventive care code use and utilization, and some of the issues around appropriateness of emergency room care and other areas. So there is some value we can derive from things when we don't have large populations, but in general, most of your value is there if your population is in fact fairly large. Second question is, what would an ideal claims analysis look like? And I would say, first of all, that both your participant and non-participant population is greater than 1,000 lives. You have multiple year data, so you have baselines to compare your current data with. The issues around per capita health plan claims costs would be the primary thing that you're looking at. No plan design or vendor changes in an ideal situation. Non-claimants are factored in, and routine maternity care and preventive service use is factored out. So you have that as separate numbers that you look at that are taken out of your analysis in terms of looking at per capita health plan claims costs. And good baseline data, you know who's in the baseline, and you have full 12 months of data on that. You have clear and edited date of service data. You have participant versus non-participant pre and post comparison, and you have the issues around both planning use of the data, targeting use of the data, and evaluation use of the data. That would what I would be considering an ideal claims analysis. And question number 3, what long-term claims analysis strategy makes the most sense? And I think first of all, first thing is you should have consistent analytic rules and processes. So nothing should change year to year in how you are computing and looking at your claims. Secondly, you should have a time series for key indicators. So that means you're looking at them each year and evaluating the change in trends that are going on in those time series kinds of data. Third thing is that some ad hoc studies are likely to be done. So you can kind of look at it and say, I think I want to look deeper at how we're handling depression in our health plan and how our wellness program is dealing with depression as an issue. So that might require some what are called ad hoc studies. We want to be looking at trend analysis. So that's another one of the claim strategies that we want to have. We want to always be looking at what's the trend that's going on. Higher order targeting for utilization and diagnostic targeting. So the ability for us to deal with some of the more refined kinds of filters, like the individual who's overusing emergency room care or shopping for specialty care, or using too much care or misusing opioids, or a variety of different kinds of things that show up frequently in our claims data system. Also, that long-term claims analysis strategy should include both the medical self-care effects, the consumer health education effects, and any effects of injury prevention strategies that would affect both worksite, home, vehicular, and recreational activity. So those are the kinds of things that I would probably suggest to you might be part of a long-term claims analysis strategy that makes sense. Now you've completed this module, go ahead and take the quiz.